Welcome back and re-engage with life, as we say. My name is Ramla Batra. I'm a primary care physician by background and chief medical officer at Scan Health Plan, and I'll be the moderator for this very esteemed panel and a very apt panel today. I have a host of folks here, as you can see. The format that we are going to follow through would be folks are going to present from their landscape, what they are doing in terms of mental health from their organizations. We have plenty of time for Q&A, and I'm hoping people will stay and ask all the right questions so we can have a very interactive discussion. I also want to kick off by thanking all our sponsors. Thank you for helping us organize this event. There were a lot of, oh my God, panic moments between me and Diane. Would people show up and all the things going on with COVID, and excited that we could actually make it happen. So thank you one more time. Switching gears and talking about mental health. So very important to all of us in this room and rooms outside of here and the organizations that are represented here. I'll share with you.
Whisper? Okay, maybe I'll go back.
Yeah, welcome back.
Hey, Bill, how do we lower the microphone volume?
It's a funny
in the Huntington
story.
room?
I never have any technical difficulties at home. As soon as I started going back to the office, all technical difficulties.
Oh, I didn't even see him.
Right? Now we are so experts in Zoom, and now suddenly we have to figure out the old technology, right? So welcome back to that. I think I'll just speak up while we are adjusting it. We serve, for those of you who do not know SCAN, we are MAPD plan. We serve about 275,000 older adults. During the pandemic, as people were getting organized and we were all working remote, in our minds, we were thinking people are going to be asking us about access to care, the fact that they cannot get their medicines or they cannot see their doctors. We made about 120,000 calls in 2020 and kept making those calls, reaching out to our members. And the thing that emerged the most was people were socially isolated, they were lonely, and they were feeling anxious and depressed. When we looked at our own mental health related burden during that time, we always knew mental health was an issue, it wasn't a problem. But when we looked at a mental health utilization, it spiked up. When we looked at telehealth, all of us know telehealth utilization went up double, 150%. For us, 65% of the mental health related visits were on telehealth. So a few silver linings that came about were people were engaged, people wanted to get access, we were having difficulty providing them with access. But good thing is with the relaxation of all those guidelines or all those policies, we were able to connect those people. Interesting facts as we look at mental health burden, 40% of the Medicaid population has a mental health related issue, whether it be substance use, anxiety, or depression. Similarly, if you look at older adults in 2020, about a third of older adults were suffering from stress, anxiety, or depression. At the same time, when we look at the supply of psychiatrists, it's a very limited supply of psychiatrists. Only 65% of psychiatrists that are here are accepting Medicaid or Medicare. So that puts all the more burden on how do we serve this population. Within our own data, when we see the utilization of ER visits, admissions, outcomes related to diabetes are 2 times worse when you have a mental health diagnosis. Many of folks on these panels I get to work with on a day-to-day basis, not Chuck yet, but indirectly through my husband. And we are always thinking outside the box to say, how do we make it happen? How do we increase the supply? What else is out there that can make this happen so we can truly solve for it? So super excited that a lot of folks here will share how are they making it happen. Also share what other things we should be thinking about in terms of policy so we can continue building access through utilization of different resources. So with that, let me introduce our panel. We have with us Dr. Robert McCarran, who's sitting on my left. He is the Director of Education at Susan Samueli Integrative Health Institute. He's also Assistant Dean, a professor in the Department of Psych and Behavioral Health at UCI. He is double board certified in medicine and psychiatry. He also has served as a director of Sacramento County Crisis Stabilization Unit and is the founding director for UC Davis Train New Trainers and Primary Care Psychiatry Fellowship. So he'll be sharing with us how are we going to scale our efforts, so not only what efforts we are doing, but how can we scale them? You can do something in small parts, but how can we scale them? Next to him is Dr. Adam Solomon, and Dr. Adam Solomon is the Chief Medical Officer of Memorial Care Medical Foundation that provides clinical oversight both to Memorial Care Medical Group as well as Greater Newport Physicians IPA. He leads all the medical aspects of Memorial Care's population health, and Memorial Care has done a lot of work around mental health at scale, and not just mental health on its own, but how do we integrate mental health with physical health or medical health. So he'll be talking to us about that. On his left is Jenna. And Jenna is the VP, Jenna Jensen, is the VP Chief Advocacy and Public Policy Officer for CHOC. She oversees advocacy and public policy for CHOC, as well as the development and stewardship of relationships with federal, state, and local elected officials. She also oversees CHOC's Belonging, Diversity, Equity, and Inclusion Initiative, and is super passionate about mental health. As we were getting ready for this panel, she was pushing on the fact, rightfully so, that we have to go more upstream and think about kids. And how can we address it upstream in the kids so we can see some kind of an improvement as they get to be adults. And on her left is Marshall Moncrief. Marshall Moncrief is the CEO of Mind OC, Be Well OC. It's a not-for-profit organization created to advance the community-wide mental health collaborative known as Be Well Orange County. He also serves as the commissioner of Orange County Commission to End Homelessness. He is a licensed psychotherapist and got his executive MBA here at UCI. So zat. So please help me in welcoming this panel. We'll start off by Robert.
Thanks, Dr. Patra, and Diane as well, and your team for putting this together. It is nice to be here in person, right? The technical issues are done, so we're ready to go forward. And great to see all of you here as well to talk about something that I think is really pretty important. I have limited time, so I'm going to be very direct with you in my opening comment here, and this is my opening comment. We're kind of in trouble when it comes to behavioral health care delivery in this country. It's not really going well. And so that's the not so good news. I'll finish strong with good news here in a second. But I do believe those who have severe and persistent mental illness are uniquely vulnerable, right? And so in many, many different ways, they're more likely to be homeless. They're more likely to die 20 to 30 times earlier relative to the patient population, usually from heart disease and strokes and things like that. Our workforce is not good when it comes to behavioral health care providers, particularly prescribers like psychiatrists. It's projected that that's going to get worse in the next 10 to 15 years, not better, but worse. And so, in fact, we see that the frontline providers are primary care providers, right? So internal medicine doc, family medicine, nurse practitioners, PAs, pediatricians, and which is fine, right? But I think the problem is this. They oftentimes did not get training on how to do this. They spend about 40% of their day, particularly in FQHCs, in underserved areas, providing this care, but they didn't get the training, right? So I'm an internal medicine doc. There's 3 years of training. Any guesses on what's required for behavioral health training during 3 years? Any ideas? Anyone want to guess? Just throw out a number. How many months? Exactly. So it's 0 minutes, right? There's really 0 time required for physician assistants in the state of California. It's 2-week requirement. Not so good. So I do want to talk a little bit later about sort of where we're at in terms of innovative strategies to expand our workforce. At the height of the pandemic, many Americans were struggling, right? And so about 40% of adults had some type of mental illness. A third of them had a significant psychiatric illness, depression or anxiety. About 10% of them were contemplating suicide. And recent information out of the state of Oregon, and this is current, 1 in 5 adults, about 1 in 5 adults in many areas in that particular state are struggling with substance use disorders. Huge numbers, right? And it got worse during the pandemic. Kids are struggling right now. They're struggling in school. They're struggling outside of school. 1 in 3 adolescents in California report serious psychological distress. And this is pre-COVID, pre-UCLA Center for Health Policy Research report. About 50% of kids between the ages 10 and 17 have some type of identifiable mental health disorder. Suicide is the second leading cause of death among adolescents. Not good. I don't want to bum you guys out yet. This is going to get better, I promise. Okay, so about 100 to 110 on average over the last couple of years, Americans died from drug overdose. And during the pandemic, this got worse. That's about 250 to 280 per day. This is a 30% increase from the year prior. Fentanyl is the culprit most often, fentanyl. In tiny, tiny, small doses that can barely even oftentimes be seen can be problematic and really kill people. Accidentally. Accidental overdose is the number one cause of death among adults in this country now. This is just kind of a quick look at, this graphic is a little spooky. This is looking at all of Europe and some other countries compared to the United States when looking at annual death rate per 100,000 people by way of overdose. You can see here at the bottom, per 100,000 people in the United States is 21.1, right? That surpasses more than all of Europe. Not good, right? And so we're in this situation now where people are struggling with psychiatric issues. About 60% of those really struggling are just not getting treatment. They're just not. They're struggling. They're suffering. They're disabled. And this is a huge problem. For those who are getting mental health care delivery, most of it is done by non-behavioral health trained providers. Most of it's done in the primary care setting. Now, as I said before, that's a little bit of a problem because these providers often receive very limited training in this area, and yet they're delivering most of the care. Not so good, right? There's a little bit of a mismatch there. Suicide rates per CDC have gone up about 30% in all age groups over the last 12 to 15 years. Again, we're heading, I think, in the wrong direction. Depression. Just simple depression, straight up depression, without any anxiety disorders or personality disorders or any other issues, oftentimes is not diagnosed accurately in the primary care setting. About 80% of antidepressants are written by non-psychiatrists, oftentimes not in the right way. So again, frontline providers delivering the care didn't get the training, right? And so that's one of the big issues. So I want to talk a little bit about some of the initiatives that we've been working on, mainly at UCI, in close partnership with many other folks, mainly using the train new trainers model, where we're able to really do targeted training for frontline providers and teaching them how to train other people in their region. So we're not just saying, hey, we're going to teach you some cool stuff, go do it, right? But we're training them how to disseminate this information in a very targeted way. We have the longstanding primary care psychiatry trainers fellowship, and also we'll be starting next calendar year the primary care training and education and addiction, or PC team training program. I'll talk a little bit about this, but before I do, I have to really show the people who are making it work the foundation of what we're doing, and that's Wendy, Camilla, and Carissa, both here today, and Jen, and a special shout out to Dr. Lee Buckland and my chair, Dr. Joshi, in the Department of Psychiatry. It really does take a team. We have over 40 faculty now, all throughout the country. Some are at UC Davis, some are at UC Irvine, UCLA, but I would say the strong majority are those outside of the state of California, many of whom are dually trained in family medicine or internal medicine and psychiatry, so they really know what it looks like. They know what primary care providers are dealing with. So what does this training look like? It's 1 year of training. The training takes place outside of normal clinic hours. So these folks get to keep their jobs. They're in the workforce, but we're training them outside of their clinical experiences. We're training them how to do a basic, efficient, evidence-based primary care psychiatric exam and assessment. And we also teach them how to treat common psychiatric conditions, when to refer, and like I said earlier, how to train other folks, right? How to train other folks within their region. Of course, we provide CME and maintenance of certification. So these are some of the topics. I won't go through all of them. We focus a lot on addiction, so pain psychiatry, pain medicine, suicide risk assessment, cultural psychiatry. We also look at trauma-related disorders, substance misuse, depression, anxiety, common stuff, basically. And this is some of the topics that we cover. We train folks from all over the country, but as you can see here, our focus is in the state of California. California has really supported this training over the last several years with scholarships for trainees who work in underserved areas. Right, so like FQHCs, for example, they're able to get scholarships to get this 1 year of training. This is how it looks in the state of California. We've really focused more on the Inland Empire, Fresno, where there are hardly any psychiatrists in the county at all, by the way, and also Los Angeles. And those have been 3 areas that we've really focused on, I would say, over the last 3 or 4 years. We also think it's very important to be working in areas where there's increased disparity of delivery of care. And so about 60 to 70% of the folks that we train do work in these areas within the state. Partnership's important. Can't do any of this stuff without partnership. Marshall, I think you've seen that with your initiatives with BWC in particular and starting that up. Recently, we've worked with the state of Kentucky, also various health plans, LA Care, Inland Empire Health Plan. We've worked with the state. Cedars-Sinai has been a really close partner with us. And then soon UAE, working with them to help revise their mental health care delivery system. This is our first class. There's about 3 or 4 of the internal medicine residents that I worked with at UC Davis, and this is our class in 2019. We're near over 950 fellows trained since starting. I want to take just a second and talk about our academic integrative medicine health and wellness coaching program. This is a new innovative approach to expand behavioral health care delivery. Right? So how do we expand it? We expand it by adding someone to the team who can really interface with the patient or the client in a way that's going to be very effective and represent what the rest of the team is thinking. Right? It's sort of the glue to the treatment team. As of the end of 2021, there's nearly 6,500 board-certified health and wellness coaches. I'll say as a point of disclosure, I work on the Workforce Education Training Commission for the state. I was at a meeting yesterday where this was a huge emphasis now in terms of training behavioral health coaches in schools, behavioral health coaches in the community. So big fan, and this is what we're doing. We're taking the lead here at UCI at the Susan Samueli Integrative Health Institute in training folks to deliver whole person care, truly holistic integrative care. So it's not just about a diagnosis and just here's a pill, but it's about mindfulness. It's about nutrition and exercise and thinking about things in a different way and training providers to think about things in a different way. There's also a strong focus on working with the underserved. This program is unique because it's nationally recognized and there's oversight by the National Board of Wellness and Coaching, also under the umbrella of the American Board of Medical Specialties. So great program, 6 months in duration, about 90 hours with a focus on behavioral health care delivery. Our first cohort started in March. It's kind of a quick overview of 19 folks. 7 out of them actually have a doctorate degree. 3 of them have an RN or a DNP. 1 is a vice chancellor here at UCI, and all have a strong interest in integrative health. Lastly, I want to take just 2 minutes and talk about our integrative transformation and education administration in children's health, or iTeach. Very, very important that we focus on kids, I think, and that this is just critically important. So one of the things that we've really started to try and work on is to try and develop a pilot where we're training teachers to understand the basics of behavioral health. What is depression? What is anxiety? What does it look like when someone's using drugs and they're in 4th grade, right? And so training them on how to do this, right, is a critical piece to this program, which we're really kind of in the beginning stages of trying to develop. In addition to that, we want to train our teachers and administrators about whole person care. How do they maintain their own sense of goodness and wellness? It's hard being a teacher. It's very difficult being a teacher. A big part of that is mindfulness, right? And being aware of your surroundings, et cetera. So this is something that we're working on right now. Always looking for partners on how to develop this. And again, I want to thank all of you for allowing me to talk a little bit about this. I certainly am passionate about it. And I think the bottom line is there's a lot that we can do in terms of building a workforce and innovation and education that can actually bring healing. So thanks so much.
So I'm going to speak a little bit more on the ground level about the things that we're doing at Memorial Care around behavioral health. So I'm assuming most of you are familiar with Memorial Care, so I won't go into this slide too much, but you can see our ambulatory sites spread from Torrance all the way down to San Clemente. Throughout, in the middle of that territory, we have 4 acute care hospitals. One of them is a pediatric hospital. None of them have a behavioral health unit in them. We were struggling with behavioral health issues. The physicians and the patients really weren't getting served very well. Years ago, behavioral health was carved out of the commercial plans for our managed care population, and so for the physician, when they were able to identify a patient that had some behavioral health needs, the best they could do is say, call the number on the back of your card. And then the patient's experience was they would call, and then they would maybe get a list, and none of those people were accepting if they even answered the phone. And there was no information back to the primary care physician. So if the patient did find someone and was getting help, primary care physician didn't know. If the patient tried and couldn't get anywhere, primary care physician didn't necessarily know. And there's a small window where you have the greatest opportunity for these patients to really get attached to and start seeing someone from behavioral health after that initial diagnosis. On our senior side, we are part of our capitation for management of the seniors includes behavioral health. And we definitely had needs that were being met by the provider we were using for more higher severity care needs, but a similar experience for the patients and the physicians for more day-to-day type of illnesses, which is really what you'll see more commonly in the seniors. Depression and anxiety by far are going to be the leading diagnosis that you see in these patients. And then additionally, because that carve-out has been around for so long, our primary care physicians basically stopped providing behavioral health services. They weren't getting paid for it, and so we're just going to follow it and give the card out. And that was after many of them not having very much training to begin with. So we've implemented 3 different things that I'm going to talk about today, just starting a few years ago, to try to address this need and improve the care that we're providing and also the experience for our primary care physicians, so they're a little bit more satisfied in the care that they're providing, and to have that integration, because even on the medical side, we are always trying to integrate. If a patient is seeing various specialists, all of that should be funneled through or focused on a primary care physician who is able to coordinate all of that care. So the first thing I'll talk about is the collaborative care program. We initiated this back in 2018. And we work with the University of Washington to implement this model where we have embedded behavioral health specialists in the office. The original goal was that we'd have the person on site, the primary care physician would identify a patient who was struggling with some depression or anxiety, and then could do that warm handoff, walk down the hallway, and actually introduce the patient. And we knew that connection would then ensure the patient was much more likely to get the subsequent care they needed. It worked very well for the first 3 sites we did as a pilot. We decided to expand it, but it becomes resource constrained when you're starting to have people in just this many clinics. Most of our clinics are on the smaller side. So we started to do a little bit of virtual work in 2019 so we could add them, and they would flip-flop between clinics and we do things virtually, which was nice. It gave us a little bit of experience doing virtual work when the pandemic hit. Unfortunately, the technology it failed immediately once we got into the pandemic, and so we changed tacks slightly. But that move to virtual was really beneficial because if you have somebody on site and they're in the middle of counseling a patient, that warm handoff isn't going to happen anyway. So we were finding that patients needed to be called back, recontacted. Once they get connected with our behavioral health specialist, they're able to do that intake, do their PHQ-9, their GAD-7, so that we can objectively monitor them for their improvement, and then do some cognitive behavioral therapy directly with the patient. Each week, we had a psychiatrist who would run through that list of patients that each LCSW was working with to hear about how well are they doing, what are they struggling with, what are the current treatment plans. And then that information was available to the PCP, so when the patient came back and saw the PCP, if they needed to start a medication, if they needed their medication adjusted, They knew what to do. They had somebody holding their hands. And as part of the implementation process, there was a good amount of education that was provided to our primary care physicians to feel more comfortable with that. The patients never really speak with the psychiatrist. It's with the behavioral health specialist and the PCP. The psychiatrist works directly with the behavioral health specialist weekly, and then is also available to that primary care physician if they need to do outreach and have some direction or have some questions that can help educate them. Right now we have 7 behavioral health specialists. They're managing 15 different sites, and we're very happy with the way the program is going. I wanted to show you some statistics on this graph. So, and just a note that since we started this, we've had almost 3,000 patients that have gone through this program. Our numbers have dipped slightly, as you can see on the right side of this graph, because we did lose somebody that we're working on replacing and actually have someone who will be starting very soon. The goal we had initially was to achieve remission in at least 60% of the patients within 90 days of that initial diagnosis. And the remission was counted as somebody whose PHQ-9 dropped below 5 after having previously been above 5. And as you can see, we're at almost 90% of these patients achieving remission within that 90 days, which is remarkable in a primary care setting. The average time is about 40 days to remission. We're very pleased with the results for the patients. And then as a side benefit to us, this is looking at, we did an analysis of the patients that were enrolled early on in the program, that we had enough data to see what were their expenses running before they were enrolled, and then what happened to those expenses. These are just medical expenses subsequent to their enrollment. On average, they're in the program for about 4 months. So there's a slight overlap through that first section, but you can see that drop in the average cost per member per month for that first 90 days, when they're still partially in the program until they're out, and that's persisted on further out. And I don't have the data on there, but this reduction, it persists beyond that as well. Another thing we implemented was something called Silver Cloud. This is a web-based application. Through Epic, a physician can refer a patient directly to this, and because it's connected to Epic, if the patient enrolls, the doctor will know. The patients can remain, if they want, when they log in and do their information, they can remain anonymous. We've had Mickey Mouse go through a few times, but many patients will put their name in there, and this can be coached and guided or independent. There are a variety of modules on numerous topics. The most common ones, again, are anxiety and depression, but there are things for sleep disorders, for adolescent anxiety, stress, eating issues, and so forth. We've had over 2,300 patients that have gone through the Silver Cloud program. We have a 68% completion rate. Right now, there are about 766 patients that are currently enrolled in this program. And just to see the benefits of this program, looking at pre on the top and post on the bottom for depression on the left and anxiety on the right, you can see this shift from those more moderately severe and severe patients down into the more minimal, mild categories. The patients really enjoy it. They can go through a few different modules and spend a bit of time there. We're using this occasionally for patients with milder symptoms, just instead of bringing them into the collaborative care model, or patients that aren't interested in meeting with somebody, as well as sometimes contemporaneously with that, or also after patients graduated from that care model, then to continue with these modules afterwards to maintain. And then lastly, this dissatisfaction with our options when the patient needs to be referred out. Because again, in primary care, most of what we're treating is the generic depression and anxiety, but oftentimes we'll see patients with higher needs. And we found that the network that we were being given by the plans was not functional. Well, we found a couple of organizations, but over the course of time, we've really focused on this company, Path. They were initially our choice for substance abuse, but it turns out that they've got the full spectrum of behavioral health support that they can provide. And their interface was so easy, we could have a patient referred to them. They would outreach within 24 hours. Patients can look, identify behavioral health specialists or providers that work the hours that they want, have the availability they want, have languages that they want, and then they can continue to manage them virtually. They do have some in-person availability that was curtailed completely during COVID and is just starting to reopen. The plans will pay for this. They're contracted with the health plans. This doesn't work for straight Medicare or Medicaid, but it will help for most of the plans. Interestingly, as a side note, for us, when we implemented our collaborative care model, we spoke with a lot of plans asking, will we be reimbursed for this? This is behavioral health technically on the commercial side. This is not part of our cap. We're doing this. This is going to reduce your costs. Will you pay? And the plan said, oh, yes, we'll pay for that. Well, it turns out that they are not paying for that. Each one of them have come back and said, no, that's part of your cap. And despite the fact that the codes are easily identifiable for what they are, technically they say they fall under the primary care section and it should be within our capitation agreement. So if there's anyone that has any ability to influence some of the plans, especially on the commercial side, to recognize that this is supplemental, this is behavioral health, and it does ultimately save the plans money because of this reduction in utilization once these behavioral health issues are addressed, that it's well worth them supporting us in our endeavor.
I'm an advocacy person. I've spent about 30 years of my career in healthcare, and a big chunk of it advocating, which means I'm just a professional nuisance for people who don't want to change their policies. So that's my job. For those of you who aren't familiar with CHOC, we are Orange County's Children's Hospital. We are a children's health system. We have 2 hospitals in the county. We have 4 community clinics. We have a rapidly growing network of primary care sites and specialty care sites that stretch out into the Inland Empire. We treat children from LA County, from the Inland Empire, from San Diego County, from all over Orange County, and we have kids flying in from other parts of the country to receive care for some of our highly specialized programs. So that's what we do. And our mental health program is rapidly growing. And I want to recognize Dr. Heather Husty, our chief psychologist, who's here. If any of you have questions that get above my pay grade on clinical issues and mental health, Dr. Husty is here to answer questions, and she is outstanding. She is a treasure for our organization. So I'm going to start out by talking to you about the fact that mental health is a pediatric disease. We don't want to think about that. We want to think about childhood as being a really happy time, right? Where what could possibly be on a kid's mind. But the truth of it is that mental health is a disease of children and teenagers. Dr. McCarron's statistics were a little bit, ours are probably a little more conservative, I'm going to say. His statistics are also accurate. This is just depending on how you're slicing and dicing the data. But the number I'm going to talk about, which is still alarming, is that 1 in 5 children have a diagnosable mental health disorder. Your numbers were higher. I'm sure they're also correct. But we like to illustrate this by saying that in Orange County, we have 750,000 children, roughly. If you look at 1/5 of those, that's about 150,000 children. That's about 3 Angel stadiums full of kids, if you think about that. So that's the number of children in our county that would have a diagnosable mental health disorder based on this definition that we're using, which is a little more conservative. So, right, 3 Angel stadiums full of kids. And how many of those receive the treatment they need to be able to thrive? Only 1/3 of those kids is receiving the treatment that they need. So we have fully 2 Anaheim stadiums full of children who have a diagnosable mental health disorder, children and teenagers, who are not receiving any of the care they need to be able to be safe and to thrive into adulthood. And so what do you think happens if we have 2 Angel stadiums full of young people who aren't getting the care they need? Well, they're going to grow up to be adults who have all kinds of very serious problems with drug addiction, with joblessness, with homelessness, with ruptured relationships, with no support system. And we see those problems. My colleagues are talking about the problems that we have in adulthood. But we know that fully 1/2 of the adults that have mental health conditions had symptoms before the age of 14. 1/2. And I just told you that only 1/3 of those children are receiving the care that they need. 75% of adults who have mental health conditions had symptoms before the age of 24. So if we're not taking care of children who have these mental health conditions, obviously we're going to continue to have this intractable crisis in adult mental health care. So we have to think about the fact that children and teenagers are having very serious mental health issues, and we're not taking care of those things. And we need to do a better job of that. So think about that Angel Stadium full, those 3 Angel Stadiums full, when you think about how many children are suffering. And in the pandemic, during the pandemic, Dr. Husty and I'll never forget the call that we had. It was probably week 2 of the pandemic when we were all running around with our hair on fire trying to figure out where we could get N95s, what was going to happen. The schools had shut down. How were we going to get our nurses to work? Charlie Golden, who's in the audience, Dr. Golden was in the command center with me, trying to figure out how we problem solved with all these things that our healthcare institutions were dealing with. And Dr. Husty and I got on the phone one day and said, oh my gosh, what is this going to do to child and adolescent mental health care? With kids out of school, with parents out of work, with fear everywhere, with uncertainty everywhere, and we know human beings do not do well with uncertainty. This is our least favorite thing and drives a lot of anxiety. And what did we have in the beginning of the pandemic? Absolutely no idea what was going to happen next and how we were going to deal with it. I mean, honestly. So no surprise that anxiety shot through the roof. So exactly what we talked about is what happened, that we saw rapidly escalating demand for mental health services. We saw escalating numbers of children reporting fear and anxiety. There were some numbers that have been reported out of China that you'll see here. That's that 4th bullet of 1/3 of the children that were surveyed there reported anxiety and fear. Not a surprise, though, really, at all. I mean, I'm sure that was the case for kids all over the world. It just happens that that was the statistic that was collected. And if we can't reach you on just the basic right thing to do of providing mental health services to children, which I think we can all agree that's the right thing to do. Children who are suffering, children who are at risk of not growing into adulthood and being able to thrive need the services that they deserve. But let's talk about the cost. So this estimate that I have on this final bullet is estimating that the cost of not providing treatment and having children grow up into adulthood with lost productivity is about $390 billion a year of lost productivity in our economies due to not providing this care. So it's the right thing to do, and it's also having a devastating impact on global productivity. So we can address this on 2 fronts, depending on who we're talking to, and certainly we use this data. We're always assessing who are we talking to and how do we convince them. So $390 billion in financial impact. This provides you with some of the numbers that we've seen at CHOC. 27% increase over prior year in kids coming into our emergency department and saying, I'm having a mental health problem serious enough that it's scaring me. I'm afraid I'm going to hurt myself. I'm afraid I'm going to hurt somebody else. I can't go to school. I can't function. It's 27% increase. Consultations, kids coming into the hospital with other concerns, and our mental health team gets called to say, we need you to come in and figure out what's going on with this kid's mental health. They came in with this other medical concern, but now that they're here, they're telling us or we're observing that they have a mental health issue going on. 23% increase at CHOC. Medical stabilization of children with eating disorders. This was just shocking. We have an eating disorders unit at our hospital down in Mission Viejo, where we take care of children whose eating disorders have gotten so out of control that they need medical rescue. So their lives are at risk based on their mental health condition of an eating disorder. We saw a 108% increase in the census in that unit. And you could look at that figure and see that it's shocking, but also you can't imagine what that meant for our organization to scramble and try to provide the capacity and the staff and everything. We were really shocked by that increase, and those high numbers have continued. 28% increase in demand for our intensive outpatient program, which is an extremely effective program, an 8-week intensive program, the aim of which is to address mental health disorders that are leading children and teenagers to engage in self-harming behavior and have suicidal ideation. It's an 8-week program, as I've said. The results are outstanding. So we've seen a 28% increase in volume there. And then just calls for services, 71% increase. So really everywhere you look across our continuum of care, we're bursting at the seams in terms of demand and just working around the clock to figure out how to expand capacity in order to serve all these kids that need our help. The good news is, when Dr. Husty and I first started making a nuisance out of ourselves in Sacramento and Washington, D.C., which was probably about 8 years ago, where we sat down and said, we've really got to start, talking more about this in public policy. At that point, I feel like we almost never talked about this in public policy. It just wasn't a topic that we talked about. And now we do, which is really promising and encouraging, I think. So we've seen the White House came out with a statement this year about the child and adolescent mental health crisis. The Surgeon General declared a state of emergency. We've seen large new investments at the state level, $4.4 billion that they're looking to invest in pediatric and adolescent mental health, which is really exciting. It still won't be enough, but it's really exciting. We will spend that money. We'll be partnering with schools to spend that money, but really exciting to see that kind of investment. A broad range of advocacy organizations, including the Children's Hospital Association, the American Academy of Pediatrics, and the American Academy of Child and Adolescent Psychiatry came out with a joint statement on pediatric and adolescent mental health, and 60 organizations signed on to that. So we're starting to see people really raising the volume on the need for this, which I think will lead to action, but we are going to have to keep pushing because oftentimes children are just not part of the conversation, and they must be, as I've told you earlier. So what is CHOC doing? And I love this slide because it's a lot. It's a lot of what we're doing in pediatric and adolescent mental health. We've done a lot of, and you can look at this, I'm not going to go through and call out every single one of these things. I do have some things circled, and I'm going to put my glasses on so I can see. Mental health education in the community, we've reached over 109,000 community members with education about how they can recognize and start to address referrals for mental health services. Our well spaces are a really exciting program. I could do a whole presentation just on well spaces. Dr. Mike Weiss and Dr. Heather Husty working together to enter into partnerships with schools to create well spaces on their campuses where kids can go for respite and to start using some coping strategies during the day and learning how to de-escalate stressful feelings and situations. So those well spaces are growing rapidly, and I'm really excited about that. And I'm starting from sort of the lower end of the continuum of care and going up to the more acute level. Integrated mental health services and primary care, which is extremely effective. Some of my colleagues here have talked about the fact that when you embed mental health practitioners in a primary care setting, in other words, if I go in with my kid and we're there for a well child visit and we happen to mention that my 8-year-old hasn't gone to school for the last 2 weeks because they're having stomach aches every morning and headaches, and we can't figure out why, and the doctor suspects this might be from anxiety. This actually happened to one of my kids, so I'm really familiar with this situation. That there's, in the cases where we have an embedded mental health practitioner, we can make an immediate warm handoff to someone who can come into the room and say, so nice to meet you. I am the mental health practitioner who works in this office. Let's schedule a time for you to come back. And we know that if we can make that introduction and help people to get comfortable with this referral, that they're exponentially more likely to come back and complete that visit. Otherwise, the odds of them coming back are really low. So having that person embedded makes a big difference, and we're making significant investments in embedding those mental health practitioners in the primary care setting. Substance use outreach, we've already talked about the growing substance use crisis, and we are focusing on that. We have a new psychiatry consultation line that provides connections for both primary care pediatricians and also individuals from schools who need to know, how do I respond to something? So we have a consultation line that provides immediate response to questions from the community. Our mental health emergency services team, moving along toward the more acute end of the spectrum, we have a dedicated team in our emergency room to respond when children and teenagers come in with mental health crisis, which, as I've said, is happening more and more. Our co-occurring clinic, which is a partnership with the county through a grant to address mental health conditions in children with complex and chronic health conditions. Interesting and important to note that children who have complex and chronic health conditions like cancer and diabetes and things like that are 3 to 5 times more likely to have a mental health condition. And this should not be surprising, but those numbers might be surprising. 3 to 5 times more likely. So when we think about our patient population at CHOC, a lot of our patients are experiencing a mental health condition that is a direct result of the chronic health condition that they've been dealing with. So we established this clinic which provides mental health services for children who have co-occurring, so at the same time, complex and chronic health conditions. And then we're working on opening a dedicated young child outpatient clinic to provide the specialized services that younger children need and be able to start providing therapy even earlier, which is our best likelihood of success when minds are plastic, when we have parents engaged, and when we can start early to help teach children how to cope with some of the feelings that they're having and addressing some of the mental health challenges that they're having. And then finally, I want to talk just for a second about our inpatient unit. So we do have an inpatient mental health center at CHOC. I think that opened 4 years ago, Heather, is that right now? I've been saying 3 years, and now all of a sudden we're coming up on the anniversary. So it's 4 years now we've had this inpatient mental health center. This is the intensive care unit of mental health. These are children who are not safe to be at home right now. They come into our emergency department, we evaluate them, and we find that they need to come into our inpatient unit for a period of time so we can stabilize them. And then the idea is to do a warm handoff back to some level of appropriate therapy in the community. It's an 18-bed unit, all private rooms, which is unique, and also the ability for parents and family members to come and visit anytime, day or night, which is also very unique and extremely effective program. We are very proud of our outcomes. We have some of the lowest use of restraints and isolation in the country in that unit. We are very proud of it. And we're excited about the outcomes that we're seeing. But it's 18 beds. And so what do we need to do? We need to keep kids from needing to get into that unit in the first place, because those 18 beds are precious. Also, it's just not optimal to have a child have to leave their family and go stay in a locked unit. Much better for the child and the family if we can address their needs earlier through outpatient intensive therapy or something else where we can keep them from getting so serious that they need to be admitted. And then let's try to reduce the length of stay to the extent possible by having appropriate levels of service to discharge kids to, so they don't need to stay as long. So we know that when they leave, they're going to be safe because they're getting the services they need. So you might say, well, why don't you just build more beds? Well, that is the most expensive level of treatment. And it is also the most disruptive level of treatment for families and kids to have their civil rights curtailed for a period of time and be in a unit where they can't come and go freely. It's not optimal. So wouldn't it be better if we could provide the services needed to keep kids from needing to go in there in the first place, and also to reduce the length of stay so that we can open up more beds and discharge kids safely to intensive levels of care? So that's kind of our focus right now, is looking along this continuum. Now, we will continually reevaluate whether we need to build more beds, and that's something that we're doing. We are looking at it all the time. And if and when the time comes that it's the right thing to do to build more beds, we'll find a way to do that. But in the meantime, what would be more efficient, what would be a more effective way to do this would be, let's see if we can build the outpatient continuum of care so that we can provide services needed in the outpatient setting. So that's what we're doing. Advocacy opportunities, I've told you I'm a massive nuisance, and I'll talk a little bit about mental health parity because that's one of my favorite topics. So Congress very recently received reports out of a study they had commissioned on how we're doing on achieving mental health parity, which is the law through the Affordable Care Act. The law says that we are supposed to provide mental health services in parity to what we provide for medical services. So they did this audit to see how we're doing. They did a review of 160 health plans to see how we're doing on reaching mental health parity. The answer, folks, is 0 of those 160 health plans were delivering parity in mental health, according to this audit. So we've got a lot of work to do. And I'm going to be talking a lot more about this, that we really need to get serious about the enforcement of what's already the law in terms of making sure that people are getting access to the services they need by having coverage for the services they need. And we've got problems both on the commercial and Medi-Cal side of things. So Dr. Husty and I are now such a pain in the neck that when people from the Department of Healthcare Services see us coming, they say, I know, because Medi-Cal doesn't cover intensive outpatient therapy at all. And we need to change that because that's not equitable for children who receive their care through Medi-Cal. They should have access to intensive outpatient therapy. I've told you how effective it is. It's not okay that they don't have access to it. And that's going to be something I will continue to fight for. I'm like a dog with a bone on that issue, and so is Dr. Husty. And then on the commercial side, we have so many providers that won't even accept insurance because of the low reimbursement that they receive. Child psychiatrists receive lower reimbursement than primary care physicians receive for the services. So we have big problems we've got to address, and that's my job. I'll continue to yammer on about that. Oh, here's the advocacy opportunity. Sorry, I got busy. See, this is what a nuisance I am. I got all busy talking about it and didn't even show you the slide. So here's the slide. I'm going to skip this one. If you want to hear more about how this can work in the best case scenario, talk to Dr. Husty. She's here. She can talk to you about some stories about how this can work in terms of using that continuum of care to make sure kids get to the level of care they receive. But I want to leave time for Marshall. And here's some resources, and we can provide this to you afterwards.
I would love to have a day session on intensive outpatient and Medicaid with DHCS here.
Yes,
I mean,
let's do it.
That is something worthwhile.
Let's do it.
For any propeller heads in the room that know that level of care, for that not to be available to the Medicaid population is pretty criminal. So what we're hearing from all of our friends here up on this panel is that the challenges in mental health are pretty big, and so are the opportunities. And so we're listening to the statistics that talk about the number of people impacted by this. And we're also listening to the dearth of providers in order to care for it. We're limited by bed number in the county. And we've got challenges and fragmentation between payer types and what services you can access or not. So a lot of tough stuff. I'll add one little data point. It's unsophisticated, but I haven't provided clinical care directly to anyone in quite some time. But every single day, I get a call on this from somebody in the community seeking support. And sometimes it's many times a day from many somebodies. And I just want to underscore, it's not every now and then, or every other day, or a couple of times a week. It's every single day. I haven't gotten my call today yet, but it's coming. So last night the call came in about 10 o'clock, and it was a family member. This is a well-resourced person that works in healthcare, couldn't be better connected, and their son relapsed on opioids and is now in the hospital, and she doesn't know what to do. And so the challenges are significant, but the opportunities are significant too, because we're also listening to, Jenna was calling out, and I think Robert too, some of the funding that's coming down for mental health is coming in ways that isn't wholly sufficient, but is it a massive step in ways that we've never seen before? Absolutely. And we're having conversations like this as a community in a way that we haven't ever had before. And that's huge. And so the potential is really big. And that's the story that I want to share with you. And I'll keep it brief because I know we want to get into a dialogue across all of us and interact with you all. But that's the story of Be Well, is what are the opportunities for Orange County to take all of the goodness that we already have going, and how do we be better? In fact, how as Orange County could we be the best? And we think we might be in a position to do that. And it sounds pretty audacious, but it's not far-fetched. We're the 6th largest county in the country, so we're big enough to matter, but we're also small enough where most of us know each other. We work with each other, and so we can wrap our arms around Orange County and get something meaningful done. So in Orange County, what Be Well is about is optimal mental health and wellness for everybody. That's what we're trying to go after. The problem today is not that we're not doing anything in mental health. We just listened to 3 super pros who are describing some really cutting edge, awesome stuff going on in Orange County. And there's actually been a ton of amazing things going on. One of the challenges that we struggle with is those things happen in cylinders, these acrylic cylinders that it's hard to connect with each other in a way that we need to. And so the way that the community who calls me and calls Jenna and calls Robert and all of us up here, Adam and Ramala, the way they experience the system is a non-system. The way they experience the system is what you're seeing on the slide up here, which is aimed to reflect the various sectors of our community, all of whom are impacted by mental health. And I don't know how well you could see the words, but those drifty flags represent the different sectors of Orange County. So you've got the healthcare systems up there, but you have the justice system, you have the faith communities, you have academia and all the rest. And all of them, if you ask any leader in any one of those sectors, hey, what's among your top 3 problems? Every single one of them will mention mental health and substance use. Talk to a teacher, a doc in any area of healthcare, talk to a school administrator or a faith leader, and it's always the same answer. And so all of them are trying to solve for the problem in front of them through the limited resources or the limited lens of their specific sector, or more limited, the organization that they're in. Amidst all that fragmentation are the people that struggle, and they're all under some kind of a label. Either they're insured or they're uninsured. If they're insured, some are publicly insured and some are commercially insured. Their acuity level varies from mild to moderate to severe. So we just created 1,000 keys and doors, and you've got to match the right key to the right door to get care. That's why the calls come through. And so the mom who's sitting in the hospital with a commercial plan, trying to find who is contracted to where I get my son out of this ICU into the right care, and is getting bounced all over the place. Like Jenna was describing, a whole list of numbers are given to mom, and maybe Adam was mentioning this too, and how well is that network staffed and who's available, and it's a maze that this person has to navigate in their time of most vulnerable. Because of all that fragmentation, the crises are increasing in Orange County. We've engineered a system where law enforcement and EMS are default responders, and so we've engineered a system where hospitals and jails are the default destination. In my last role, I worked for my boss. I can't get away from this boss. He's here with me now. And with Dr. Afable, who's in the room, we oversaw 14 hospitals, and my role was overseeing mental health and substance use. And so I got really familiar with the data. In Orange County, every year, 50,000 people are in the ER for substance use or mental health needs. That's the wrong environment for a whole lot of people. And there's some remarkable efforts, like Chalk just described, of putting mental health care in the ER. There's some amazing teams at all of our hospitals that work super, super hard, but that's the wrong environment, never designed for that level of care, and we get subpar outcomes at best for a cost that's about $100 million to this community every year. So how can we as Orange County get better? And so Be Well wants to take all of those drifty flags and unify it into an ecosystem that wraps a hug of support around all of Orange County, regardless of what their payer status is or their clinical condition. And really importantly, when I say Be Well wants to, that's not one organization. So that's not Marshall and Rick and team of people. That's everybody up here on this panel who are leaders in this community-wide effort that we've called Be Well Orange County. And a bunch of you in the room have been participants and leaders in Be Well Orange County. And so that's what our aim is to address the provider shortages, address the bed shortages, address the growing needs by coming together as a unified community and creating one unified system of care. And so that's the goal. The way that we do that is we created a blueprint. And so the whole community came together and said, if we had a world-class system of mental health care in Orange County, where would we be moving the needle? And we came up with 6 result areas: stigma reduction, prevention and early intervention, closing the treatment gaps, so sort of some upstream kind of stuff, improving our crisis response system, anchoring that with these comprehensive campuses that are available to anybody, regardless of their payer status. Those are kind of downstream. And then aligning policies, programs, and data, and that's our 6th result area. An example of that would be the effort in homelessness in Orange County has to be aligned with the effort in mental health, or else we're not going to move the needle in one without the other. So that's how we're organizing ourselves. And all of those little gray circles around each of those 6 results represent the organizations that are already doing work in that space. And we're not asking everyone to homogenize. We're saying, can we rally around some things in each of these 6 to do together as a community? And as a community, we created a little not-for-profit that tries to organize the community and move these things forward in a really meaningful way. And that not-for-profit is called Mind OC, purposefully not named Be Well, because we want everybody to own Be Well. Mind OC, this little legal entity that we use to get work done, is just another partner in the mix. So this is the way that we're bringing Orange County together. And we stumble, and it's clumsy, and oftentimes we have to find each other in the dark and say, Jenna, are you still there? Is everything okay? I think I just stepped on your toe. I didn't mean to do that. And reconnect, because it's tough work. And we're trying to break through the acrylic cylinders and hold hands to move this thing forward. But we are making demonstrable progress too. And so the challenges are significant, but the opportunity is equally significant. And as a sign of kind of getting some recognition or other people sort of paying attention, which just indicates we're making progress, Sacramento came over recently because they wanted to study what we're doing in Orange County and may be interested in a learning collaborative. Javier Becerra, the HHS secretary, wanted to come over and take a look and, hey, how are you guys unifying community? There may be a lesson here for other counties. And so there are some good things happening. Out of all of those 6 results, we do see some concrete infrastructure that needs to get created. And so we need a unified navigation system. So instead of calling Jenna or Adam or Robert or Marshall on your cell phone when you're in the ICU, do we have a coordinated system that's really easy to connect with that can guide you to the needs that you have? Right now in Orange County, we have 18 different phone lines that deal with mental health. All of those were created for a really good reason, but the community doesn't know which of those to call for when or why. So that's why somebody calls go to 911 and we deploy the system we do and we get the people to go where they go. So the navigation system is critical, linking to a continuum of mobile response So can we go out and meet people's needs in community where they are better than we do today? We have some services today. Can we meet those needs even better with an expanded continuum? And those would go to potentially these regional campuses when the need is there. If we can decompress needs by way of better navigation and mobile and meet the needs in community, avoid facility-based care, that's even better. And all of that has to be undergirded by a creative network of providers, because we're hearing there's not enough, or there's not enough contracted. Dr. DeMarco, who's sitting in the room, talks about the hidden network of providers, that there actually is a bunch of people out there that we can harness to get this done. We just have to create something compelling enough to pull them off the bench and get them active, contracted, and working as part of a system. And then you heard Dr. McCarran describing what UCI is thinking about in getting creative certifications to community health workers to say there's a whole bunch of people out here that we could unleash to be part of the solution. So the challenges are big, but the opportunities are big too. And then I'll just show you really quickly, and then we'll wrap up, Rama, as an example of the way this infrastructure is starting to manifest. Be Well has recently launched a mobile program that's working with cities, with law enforcement, in support of law enforcement, in support of EMS, and in support of community, and as an absolute expression of health equity at a city level, and going out to mental health and substance use calls instead of law enforcement when those calls are non-violent, non-criminal. And it's really making an impact. In Garden Grove, where we've been live about 9 months, most of our team is Vietnamese or Vietnamese speaking to reflect the community that's largely populated there. There was a 75-year-old homeless gentleman whose primary language was Vietnamese. Law enforcement had done really a compassionate, beautiful job of engaging him over years. He always refused to go into care. Our team was active with him for about a month, and he's now housed. And so, to me, that's local, that's health equity. So the way this thing works, real quick, call goes into 911. A dispatch person like that has 3 tools to deploy today, and we're just adding a 4th tool. And that's the way it works. So we have vans that look like that. They're staffed with 2 crisis counselors that go out. One of those people has a medical background, and the other a mental health background. We're not trying to be medical. We're not trying to be EMS, but we're trying to be smart enough to pull the lever when we see something that needs medical attention. And the goal is avoid facility-based care, stabilize in community, and get people connected upstream, exactly like Jenna was talking about. We need these facilities, and we need beds. And everybody was just like cheering when Chalk stood up the first pediatric beds for this county, and at the quality they did. But yeah, if we could avoid a child being in that unit, that's a win. And so it's not about scooping people up and taking them to facilities. It's about getting the community and stabilizing where they are. Sometimes you need facilities. And so you saw the campuses as part of that network. And so in partnership, in fact, a unique partnership, Be Well, again, not a company, Be Well is the whole Orange County community, stood up the first regional campus that has a full continuum of substance use and mental health services, including the county's first adolescent crisis unit. So what we're talking about with Chalk is, boy, if we could reduce some of that pressure on the ER and have kids in an environment that's less intensive than an ER, and then get them transferred to the whole continuum that Jenna has at Chalk, what a win that would be in those acute moments. The better win is that they don't go there at all. But the cool thing about this campus is that it's really a first of its kind in the partnership it reflects. And so many of the county's most visible nonprofit health systems collaborated with the County of Orange and CalOptima, the Medicaid plan, to stand this thing up together. And that's pretty unique in Orange County. And a sign that we're moving the needle here together in building a system that's for everybody, created by everybody. So I know that was super fast, but that's it for Be Well, and we can talk a whole bunch more.
Oh, well, what an inspiring conversation on the hump day. Super inspiring. I'm so excited to be an Orange County resident and knowing all these resources that are available. And what all of you have pointed out to is a principle that IHI states, assume abundance, which is don't look for specific resources. Their resources, are we using them wise enough? And so all of you have shared with us how you use the principle of assume abundance, the hidden network you spoke about, the going upstream, the behavioral therapist, the training of our existing, folks to be coaches, behavioral health coaches. That is all assume abundance. And I'm going to pass it on to the audience so they can start asking questions. The big question that comes to my mind is, as we think ourselves in our organization, think about access. There's no way we can get enough psychiatrists and psychologists even if we wanted to. And so what we've been thinking, the way we've been approaching it is like, let's get the people who really need to see a psychiatrist, psychologist there, because that's the best match we can do. And then we have to make sure it's linguistically competent and culturally competent. But how do we create additional capacity in the system? How do we create additional access in the system? And so Pedro is sitting in the back. He started our first licensed clinical social worker program that have been trained in CBT, go in the homes, provide that culturally competent care. We're looking at our own members and peers. We are training them as coaches so they can do that. So we'd love to hear from all of you as you're thinking of building, that's one example, as you're thinking of building capacity in the system, even if you were to fund multiple psych programs or psychology programs, we're not going to get there in the next 2 decades. Are there other things you're thinking about? Your concept is an amazing concept, and obviously I'm going to reach out to you after this to see how we can train more folks. But are others using other kind of resources to build that access for perhaps the mild, the moderate depression, the anxiety, the stress, the resilience, so that we truly can use those resources for those that need the most, the seriously and persistently mentally ill? We'd love to hear from that, and then after that we'll open it up to the audience so they can ask questions. Anyway.
Any of us? You're going to go, Jenna?
I mean, I talked about the education that we're doing, the numbers I cited, high numbers of outreach to lay people in the community to provide them with, mental health first aid training to be able to identify and start to address challenges that they see. We have a very excellent training program, so we are providing internship and postdoc training for pediatric psychology, and I'm happy to say that program is growing all the time in terms of its stature in the country. It's a very highly respected program thanks to Dr. Husty and her team's work. So we are bringing the best and the brightest to this community to train for pediatric and adolescent psychology, and we're hanging on to them. God bless, they're staying. They like what we're doing here, and we're hanging on to them. So recruiting and retaining people to go into the field. I talked about our well spaces and partnerships with schools. I talked about our consultation line that provides resources to primary care physicians and school personnel that need help to figure out what to do. So all of those programs are important ways to get expertise out into the community. I will also say just one caveat, and this is probably the main reason why I pushed my microphone, and Dr. Husty will probably know what I'm going to say. There's an awful lot of dialogue now about looking at alternate care delivery models, looking at using lay staff to be able to provide services and expand access, and that is outstanding and something that we need to do. And also, I'm going to say we need to be careful because, especially with kids, providing trained services to children who are suffering, who are maybe harboring suicidal ideation, maybe harboring homicidal ideation, and these numbers are higher than any of us want to think. These are very volatile situations, and ensuring that we have individuals who are properly trained to be able to address those things is critical. It's a matter of life and death. So while we're having these conversations about deploying people at alternate levels of care, ensuring that we are also focusing on training, recruiting and retaining the best and the brightest to go into this field by providing adequate reimbursement and enticement for people to go into this field, which entails very high levels of burnout. This is a very difficult career for people. So let's provide proper incentives for people to go into that field, because no matter what we do, we are always going to need highly trained individuals doing this very difficult work in pediatric adolescent psychiatry and psychiatry. So again, I told you I'm a professional nuisance, so you invited me here, this is what you get.
Yeah, I know, and I have to just point out that in my career and probably lifetime, I don't think we're going to have enough psychiatrists in this country, in many areas of this country. And there's many reasons for that. But I think it makes good sense, like Patty was saying, to find those hidden providers, right? And to go to different levels. And so I think, I know that the folks who are delivering most of this care are struggling. They're struggling because they don't really know how to do it. And they want to know how to do it. They can manage blood pressure and diabetes pretty well, back pain, arthritis, but depression, anxiety, I don't do that. That's not what I do. And so if we can really try and increase their training in this area, that's going to be very helpful. And then at BYOC, I can say, Marshall, I know that with this mobile unit, there's a lot of training and people to get out there and do this. Very regimented, involved training on how to do this. So again, utilizing different folks in the community, folks who can relate to the people that they're working with, is going to be really important, I think.
Oh, sure. Yeah. I mean, it's a yes and a yes in my mind, that we absolutely have to expand beyond the licensed provider. And to underscore what Jen is talking about, we can't do that lightly. And so, for example, and Robert mentioned it, a lot of the people that are on the mobile vans are not licensed clinicians. So actually, Dr. McCarran is our medical director there and is helping us to standardize a training for these folks so that they know how to respond appropriately and safely. I'll say, though, I guess the thing I would add is I've got a friend who talks about healthcare as everything from Band-Aids to brain surgery. And mental health is the same way. And so we think about mental health and our brains kind of go to the acute moment, but it's a breadth, just like Band-Aids to brain surgery. And so a lot of times when I go to see my primary care physician, I don't see my primary care physician. I don't know where the heck he is. But I see somebody who's absolutely competent for the visit I'm having. And I get great care. And so I think we want to start to leverage that in mental health too, with the underscoring that Jen is pointing out of, and you can't just toss somebody in there because who knows what's going to come up. So
Absolutely. So I don't think it's either or. It's this and that,
yeah.
and in a particularly protocol-driven way, using evidence-based approaches like Adam, your team's been doing. Collaborative care model is not new, folks. It's been there for like 20-some years. But perhaps there also has to be change in payment and policies, because if you are deploying those resources, if you are spending those times, and you are saving, and you have data points to show that, then you should be reimbursed for that. Similarly, like peer coaches, licensed clinical social worker, there has to be a stream so you can afford to have those kind of folks. I totally get it. I would love folks from the audience, if they have any questions. I think it's a small group, so we can absolutely raise our hand and speak up. Go ahead, you first. She has a microphone. Diane's coming with a microphone.
No problem. Well, first of all, thank you. Amazing panel. I think you're all trying to individually dismantle decades long of neglect of our mental health system of care, starting from the 70s, the institutionalization to systematic defunding of behavioral health infrastructure. And now we have what we have today, which is, this kind of fragmented. And each of you touch on dismantling system-level barriers, provider-level barriers, and patient-level barriers. And that's no easy task. That is very noble work, from workforce to collaborative to building a vertical continuum of care to gluing it all together. That is amazing. So thank you for the work that you do. The first question goes to Dr. Solomon. So as we heard, collaborative care is not new, but over the years, other than the VA, many systems of care have miserably failed to implement it and sustain it because they have not seen the return on investment, right? They've seen that there's no direct lines of revenue, but they have not been able to show that by savings on the back end, that you'll be able to save a lot of healthcare costs. So my question with your 90-day incremental cost analysis, if there's any, number one, what are the plans to scale it to size for the whole memorial care system if you are planning on that? And number two, to use that metric, because not many people have the right metrics, and which is why usually true AIMS model based of University of Washington sunset after about a year of a pilot, 1 or 2 years. Because they run out of steam. They're either funded by, a one-time investment through philanthropy, or they're funded by one-time, overhead the hospital can spend, and so they're sunset over time. And so my question is, are there any initiatives to take those metrics to the state level and advocate? Because collaborative care works. I think the data is pretty clear. Now, luckily, the pandemic has given us a boost in awareness, and the stakeholders are finally engaged, but we need to take it and scale it to size. So what are the efforts in the way to scale it and to show at the state level that this thing works?
So it's a great question. And as you noticed when I was speaking, most of the patients that I was addressing are our managed care patients. And this goes back to something that we've advocated for a long time. And the state of California is ahead of most of the rest of the country, is on this delegated model where care is provided by the provider organization that helps to manage the full spectrum of care for individuals. I think one of the reasons we implemented this was we found that not only were we dissatisfied with the quality of the care the patients were receiving, but when we looked at our senior populations and we took similar populations with similar diagnoses, but where there was an additional behavioral health diagnosis in one cohort compared to the other, their costs were 2 to 4 times what we were spending on the medical side from those that didn't have that additional diagnosis. So to us, it seemed to make sense. If we implement this, we will save the money on the medical side, even if we're not getting anything additional on the behavioral health side. And as you can see from the data, that supports that position. So when we scale this out and we go to the commercial side, our level of risk that we have there is slightly less. We don't get the institutional payments necessarily. So that benefit, a good portion of the benefit, goes to the health plan. So the health plan is able to get that benefit without paying for it. And so there's no incentive for them to support the program. We are struggling with, do we continue to offer this to our commercial managed care patients? Because the financial rationale for us starts to fall apart a little bit. But it is better care, the doctors are happier, the patient is getting better service, and there is some benefit on the professional side, so we are continuing that. But as you start to get out to our other populations where there is no payment to us and no savings to us, then it is a community service that we're doing, which is great, but unfortunately with margins that are basically zero, it's hard to add additional resources to the benefit of the community that don't somehow support those efforts that we have. Right now, all of the work is being done within our foundation. Our foundation model, we have a large medical group, Memorial Care Medical Group. We also have a group of independent physicians, Greater Newport Physicians, IPA. And this would be an unusual model to roll out to an IPA because these are offices with a doctor, 2, maybe 4. And to have somebody embedded there, you'll never make that make sense. So being able to do it virtually has helped, and having the scale that we have has enabled us to cover several of our IPA offices with one behavioral health specialist. So we've been rolling this out to our IPA doctors and expanding to that additional population. But again, that population is our managed care population. So I agree with you. There should be support. And until we get past this problem of the financial incentives not aligning where those who benefit can get that benefit without any extra efforts, it's going to be hard to expand it to the full population.
Patty, there is a bill, actually. I was trying to look it up, but I don't have internet access here. But there is a bill nationally, not statewide, $30 billion bill to support collaborative care and primary care.
Yeah.
And that's sponsored by the AMA, American Psychiatric Association, and all those other associations, pediatricians, and I don't know if you're familiar with that, but it looks like it's probably going to pass. There's a little opposition, but if that happens, that's a big deal for collaborative care in this country.
There's also a lot of national calls around push for having, just like we have annual wellness visits and older adults having behavioral health or mental health visits and them being paid for. I think that payment stream is so very important, and that's where value-based contracts, where you're getting the upside and the downside risk, pushes you into thinking outside the box, pushes you into scaling and innovation. Like Silver Cloud, we collaborated together, like payer provider, to say, how can we create access in the system? And so that was a digital technology tool to kind of build on the access, build on the bandwidth. So the right people went to collaborative care, and then the right people then went from there to the psychiatrist so that you can match them. So it's a whole continuum of care. I think that also becomes very important.
Yeah, I will say that during the pandemic, as an organization, we recognized the community need for behavioral health services. And so that Silver Cloud program, we offered it to the full community for free. We just felt like it's easily scalable at the costs we were paying, and it was a benefit to the community during a time of stress. So a fair number of that, nearly 3,000 people that had enrolled, really weren't even necessarily, we don't know, but not necessarily our patients. There are people in the community that receive those services. The other thing I'll mention, for a recent expansion we've had in the population, one of the government programs for Medicare patients is Primary Care First. And it is, in essence, a way of capitating primary care services with the goal of reducing inpatient admissions. And for us, again, treating behavioral health conditions in seniors, depression, anxiety, is clearly going to reduce those admissions. So we're offering those services now to our Medicare fee-for-service patients as well.
Good morning. My name is Jennifer Wang. I'm the Chief Operating Officer of the Asian American Senior Citizen Service Center, also known as ASCSC. And first, I just want to introduce yourself, because one of the caveats of behavioral health that many of us in the nonprofit world talk about is, where's the cultural competency, where's the language access? And everything that you really presented here, there was so much to absorb. It's actually very inspiring. And we want to be able to duplicate that in terms of, well, how do we do that for our seniors? How do we do that for our youth? And I would say the pandemic really has opened a lot of doors for us. Last year, in January, we were the guinea pigs to vaccinate the seniors 75 years and older when that happened. January 10th, we vaccinated 220. And that's in partnership with Mercy Pharmacy, a private entity. We got that permission from the healthcare agency, and we see this as a model. When you mention mobile care, for us, that's what we've been discussing. How do we duplicate what we've been doing? At the end of June, we will have 240 clinics. And for us, that's not something that was in our strategic plan at all. Right? I don't think the pandemic was anybody's plan. But for us, we pivoted, and we know that we can do it, but we need to do it as a collective. Marshall, I really appreciate what your screen there and what you said. It's a hug of care, because that's what we're doing. We're trying to provide this holistic approach. And I just wanted to present to you guys in terms of, how do you guys see integrating cultural and linguistic competency? How do you see working with grassroots organizations? Many of my colleagues, yes, they're part of Be Well. And it is on our sort of like list of, okay, we need to join Be Well somehow. But I have to thank Be Well. Tomorrow we're hosting an ACES event. It's going to be a huge, amazing event, very rich program tomorrow in Irvine for our kids. And we do have chocolate. We do have a list of amazing providers. And one of the sort of things that we just wanted to prioritize is, please provide providers who can really be able to communicate with the families. Because we get calls all the time from the districts, from teachers saying, you know what, we do have a list of resources, but we need language access because we can't communicate. Thank you.
Yeah, thanks so much. And one thing that comes up for me among 1,000 as you're talking is the both and we were talking about, where, yes, all of us need to emphasize cultural competency training and be seeking recruitment into the clinical field and the clinical world that is as colorful as our community, as diverse as our community, and going at it the other way, we can also empower connection to families by using people of the community. And so, there's lots of conversation about evidence-based care, has to be there, totally get it, and Robert will be a huge champion of that. But there's also sort of community informed care. And so the people of the community know what that culture and community is and what their needs are. So can we harness some of them to complement, sort of supplement the clinical side? And so maybe that both and holds some potency for us all. So thank you for your involvement, and looking forward to working with you. Tomorrow should be cool.
Well, what an amazing dialogue. I'm bummed that we are at the end of our discussion. It was extremely inspiring for me to hear all the great innovation that's happening. And it's not only innovation, it's happening at scale. Because all of us that came very solidly through, we are thinking about how can we do at scale? How can we do it across the continuum? And Jenna, while you are advocating for policy, we are also all advocating for similar policies around mental health parity, and how can we take people from the community and make sure they get reimbursed so we can continue adding capacity to the system. Thanks to the audience for joining us. It was truly a pleasure to have such an engaged audience and be able to meet in person. Big shout out to Diane, who has been working hard behind the scenes and making it happen. And thanks to the sponsors who made it happen. Thanks a lot, folks.